Okay, so good afternoon, ladies and gentlemen. I think we'll make a little start. Sorry for being a little bit late to start this afternoon, but welcome to Staffordshire Health and Wellbeing Committee this afternoon. So we will start off with welcome and routine items. Once I've done the apologies and that, then we'll just go around the room. People can introduce themselves. There's a few new people who've not been here, so for the purposes of them and yourselves, we just go around with a very, very brief introduction of who you are. So first of all, could we have apologies?
Thank you, Chair. I've received apologies from Phil Pusey and Ian Reid.
Lovely, thank you. Anybody else aware of any apologies? Okay, I'll take that as a no. And any declarations of interest? No? Again, there was silence. Okay, so if we do the minutes of the previous meeting, take those as they are, unless anybody has got anything that they would like to raise, either for accuracy or any matters arising. No? Okay, we'll take those as read. And I understand that we do not have any questions from the public. Okay, thank you. So, so we'll just go around the room introducing ourselves. So I'm Mark Sutton. I'm Staffordshire's lead member for children and young people and chair of this meeting. And to my left is...
Good afternoon, Councillor Julia Jessel. I'm Cabinet Member for Health and Care and Vice Chairman of the Health and Wellbeing Board. Thank you.
Good afternoon, everyone. I'm Rita Heseltine, Deputy Leader, South Staffordshire Council and Cabinet Member for Regulatory Services.
Good afternoon, everyone. I'm Ben Richards. I wear two hats. I'm the Exec Director of Operations at North Staffs Combined Healthcare, but I'm here today in my role as the Portfolio Lead for the Mental Health, Learning Disability and Autism Portfolio for the Integrated Care System.
Good afternoon, everyone. My name is Baz Tamis. I'm the Manager of Health Watch Staffordshire.
Good afternoon, everyone. Karma Warren representing Michelle Hickmart from Staffordshire Fire.
Good afternoon, everyone. I'm Neelam Bhardwaj. I'm Director of Children and Families for Staffordshire County Council.
Hi, I'm Councillor Jill Heason from Newcastle Borough Council. I'm also their portfolio holder for Community Safety and Wellbeing.
Good afternoon, I'm Tim Clegg. I'm Chief Executive of Cannock Chase District Council and Stafford Borough Council, and I'm here representing the District and Borough Chief Executives.
Richard Harlin, Director of Health and Care for Staffordshire County Council.
Hello, Paul Edmondson-Jones. I'm Chief Medical Officer for Staffordshire Stoke-on-Trent ICB.
Hi, Claire McIver, Assistant Director of Public Health here at the County Council.
I'm John Toff. I'm Senior Commission Manager in Health and Care, and I organise the agendas and stuff for the Health and Wellbeing Board.
Afternoon, Liam Arch, Member in Democratic Services Support Officer.
Gary Jones, Support Staffordshire.
Okay, thank you everybody. So the item 2 on the agenda is maximising the role of the Health and Wellbeing Board, the forward plan and strategy. I think, John, you're going to take us through that on?
Yeah, I can do that. I'll do a very quick run through. I'm assuming most people have read the paper that's with the pack. Really, this is an attempt to bring a little bit of order to agendas and around the strategy that was agreed last year as much as anything. So if you remember, we agreed the Health and Wellbeing Board strategy last June, and we also agreed that we would have leads for the strategy and a board sponsor for each of the items in the strategy. So what this paper really does is kind of outline what we know about who those leads are and who the board sponsors are, but also outlines a timetable, I suppose, a rolling timetable, so we can pick up each of those priorities at each meeting. So fortunately, we have 4 meetings a year, and we have 4 priorities. So that's not too difficult to work out how to put those two together. So you'll notice that mental health's on the agenda today. It's probably a little bit premature in terms of moving the strategy forward, but certainly as we move forward, the next one I think is healthy ageing, and that will be a case of what's in the strategy, what's going on in the world of healthy ageing and frailty, and how we're moving forward in terms of baselines and actions and things like that. So it will be an opportunity to try and really generate some traction for the strategy, I think. I certainly hope so. That will be the idea. And that was really it. So if you notice, the paper just goes through reminds people of the strategy, reminds people of the indicators, reminds people or updates people on what we know about the board sponsor and the leads, and then moves into what a draft forward plan that moving forward would be for the board. So we've got a draft forward plan which can be added to, but the substantive items that we'll pick up at each one. So in March we'll pick up in March we'll bring some strategy indicators. So the strategy around the 4 priorities, we'll bring a set of indicators to say what the baseline is for each of those, so we've got some clarity on that. We'll talk about healthy ageing, as I said. The Health and Wellbeing Board is statutorily responsible for commissioning intentions for, it was the LCCGs actually, but there's one, next March we've got one down as integrated care strategy, the ICB essentially, and the commissioning intentions around that, Paul. So that will be a substantive item on the agenda. And Better Care Fund, which is part of the core business of the board as well. And it kind of rolls on. You can read that for yourself. But it's just to give some structure to kind of moving forward, so we're kind of a bit clearer about how that works and how it aligns with the strategy. Does that make sense?
Thank you very much for that, John. And Paul, I don't want to put you particularly on the spot, but part of it we were looking for to have a board sponsor for each of those 4 areas, and we were hoping, and I think I'm right, I did write to Peter ask whether the ICB would nominate somebody to be the board sponsor for good mental health, and we've also nominated a lead officer from the County Council for all the 4 areas, and we were hoping that perhaps the ICB would also match that and have a lead person. That's at the top of page 9, so not necessarily want the answers and names or whatever here at this moment, Paul, but whether you could comment on that.
Yeah, thank you, Chair. I'm very happy to do that and look at that, and I know we've had some correspondence in the last sort of week or 2 around that. The way that the ICB and the ICS is organised at the moment is around the 7 portfolios, and these 4 areas align themselves very neatly to 4 of those portfolios. So what we need to do is to make sure we've got the synergies across those, and I think the aim in all of this is to make sure we're all pointing in the same direction. We're all trying to make sure we don't duplicate, but we reinforce, we do things together. I'm very happy to go away and look and nominate somebody for the ICB to lead that, but also we will link in, probably through our clinical directors, to those 4 strategies for you, so that you've got a key link into our portfolios for that.
Paul, that's excellent. Thank you very much for that. So any other questions or anyone else want to say any comments on that? And I know Julia's indicating, and I haven't forgotten you, Julia, so there's nobody else. So, Julia?
Thank you very much, Chairman. I didn't realise you could see out through your left ear. Yes, one is a question and a bit of a plea for the future. But first of all, I would like to say I think this is a really good approach. And actually will enable the Health and Wellbeing Board, in my humble opinion, to have a bit more clout and start to be able to report on, monitor and drive the delivery of the changes that are needed to achieve what we want to. So I think this is an excellent start. I think obviously it's developing a reporting process on those key indicators because with the best will in the world, everything you do is not a guarantee that it's going to deliver the results. And if it doesn't, you try something else, because a lot of this is changing people's behaviours, which is not an easy science. But I think this is an excellent start, and I think will enable this board to be far more effective. So, certainly that's a brilliant piece of work. The only thing I would say, and it really is for the future, because I recognise it's part of the strategy for health in early life. you know, increasing breastfeeding. I think it's more really about making awareness of the benefits. I am aware of some young mothers who, with some slightly overzealous health visitors and midwives, and being made to feel a little bit inadequate and you know, as though they've got a guilt because they're not breastfeeding. I think it's a personal choice, but I do think, yes, it's absolutely right that people are, you know, made aware of the benefits of breastfeeding. But the other thing that I am a bit concerned about is the prevalence of alcohol consumption with pregnant mothers. And I just wonder if for the future we could consider in with reducing smoking in pregnancy to actually include reduction or elimination, if at all possible, of alcohol consumption. It's a similar process. Once you're sat down with an expectant mum, you know, with or without their partners, to go through those conversations. And from reading articles on it, the prevalence of alcohol consumption with expectant mothers is probably now more of a problem than smoking. So it's a question really, and a plea for, you know, when we refresh the strategy, whether actually that item can include smoking and alcohol consumption. Thank you, Chairman.
I'm sure as we go forward we can look at the consideration of those and the evidence base for that. No problem at all. Tim, I think you.
Yes, thank you, Chair, and very happy to take on the role of sponsoring the healthy weight element of the agenda going forward. Just in the interest of demonstrating a little bit of joined up thinking as well. In this very room this morning, we had a meeting of the Staffordshire's Leaders Board that brings together the leaders of each of the local authorities across the county. At the next meeting of that board, we're hoping to take a paper on health inequalities, which Claire and John have been putting together, and which Dave Hayward, who's the Chief Executive of South Staffordshire Health Authority, and myself have been party to. So that may be appropriate at some point in the future to bring that to this board when that's been discussed by the leaders. And the other thing to mention is that Dave Hayward and myself have been put forward by the Chief Executive's meeting to work with Paul and his colleagues on the prevention element of the programme that Paul made reference to earlier. So I hope we can perhaps begin to join things up a little more than perhaps we have done in the past, Chair. Thank you.
Tim, that sounds all very, very promising. So, any other comments? John, do we have to actually physically endorse this at all?
I think we just need to make sure that everyone's in agreement with the recommendations, really.
So the recommendations for this paper is the board has been asked to confirm and agree the board sponsors and officer leads for the strategy, and we've heard that that's going to be done. Be reminded that leads will be asked to report on the performance metrics and actions signed off by the board. C, review and approve the cycle of reporting on the strategy priorities and communicate this to the identified leads. And D, review and approve the forward plan timetable. So I think the easiest. Is there any dissenters or comments in that? I'll take that in that case then. No, I take it that. Okay, so the next item on the agenda is the mental health strategy, and we have with us Jan and Chris, is it? It is Chris, isn't it? Yeah. First of all, I'll make an apology to Jan for that conversation this morning, and I was dead right. The BT operative up the pole did use his pair of secretaries to cut the connection, as you would have realised. So yes, so over to yourselves then. We're all ears. Jan, if you just want to introduce yourself and your role.
Oh, thank you. Hi, I'm Jan Cartman-Frost. I'm a Senior Commissioning Manager in Care Commissioning in Health and Care. Want to introduce yourself, Chris?
Yeah, and I'm Chris Stanley, Commissioning Manager in Public Health.
and apologies from Karen Coker from Children's Services who can't make it today. So, glad I've printed it off because I haven't got the right glasses to look it up. So, yeah, as you've indicated, we've come to talk today about the Good Mental Health Strategy, which we've been working on leading from health and care. And this presentation today helps us to link it into the health and wellbeing strategy, good mental health priorities that are already included in that strategy. So we've included the vision here from the health and wellbeing strategy, and that links into the vision within the good mental health strategy that we are taking through governance currently. So in developing the strategy, we've looked at a number of existing strategies and plans. This is a joint strategy with the ICB, and there's a number of plans and strategies already in place that support the improvement of mental health and mental wellbeing in Staffordshire. So I've already mentioned the health and wellbeing strategy, Staffordshire and Stoke-on-Trent, the existing children and young people strategy, which is still current, the suicide prevention partnership plan, which Chris leads on, and then obviously for NHS colleagues, the Staffordshire and Stoke mental health plan, implementation plan, and the NHS community mental health transformation plan. So I've just included in here some of the high level stats that we've included in the strategy. These are drawn from either ICB, NHS data or the JSNA, both for adults and children. I wouldn't normally suggest I'd read through them all unless you'd like me to. So what we focused on is the occurrence of mental health conditions in Staffordshire and Stoke-on-Trent for adults. We've got higher than average incidence of depression and suicides. We have identified, obviously a key thing for us is that mental health problems start before you're 18. So although the strategy is focused on adults, there are opportunities in earlier life that will help people, their mental health and wellbeing into adulthood. And there's also some data there around the incidence of mental health and wellbeing issues for younger people and for mothers. Moving on. So the development of the good mental health strategy. So as I've mentioned, it's a joint strategy with Staffordshire County Council and the ICB. The focus is on adults' mental health and wellbeing, but there are elements where that connects into the children's mental health and wellbeing strategy with a focus on young adults and their transition into adulthood, so how that can be better joined up and prepare them for adulthood. So as you can see, the strategy has been in development for just over the last year. So we had a period of engagement and consultation, and we had about nearly 700 people that contributed to that. We had a public survey that we had over 600 responses to, which we asked about how's your mental health in Staffordshire, and we got some really great qualitative information back from people about how it was in Staffordshire for them. And we did a range of interviews, focus groups with professionals, stakeholders, partners, and people with lived experience, user groups, and senior leadership members, etc. So that took place over that period. We then had a period of analysing and assimilating all that information that we had, and we did quite a lot of research on sort of current research on mental health and wellbeing. We then have spent a period of time drafting the strategy, and it's gone through various iterations. The main challenge being it's a huge subject area to get it down to something that's quite manageable, and which Richard and Julie have been very good at keeping me on that, and that's been very good. And that was a period of sort of consulting on that and working with the ICB and public health colleagues and children's, and that was to develop a final version, which we've come to talk about today and is going through SCC and ICB governance now. Informal cabinet is next week. So once the approvals are through and it's all signed off, then we will do some work obviously to launch the strategy, and we will start another piece of work which will be co-producing an action plan to deliver on the outcomes of the strategy, and then it will be monitored going forwards. So the strategy outcomes, so we've got 6 key outcomes that we have identified in it. I'll just talk a little bit about, flesh those out slightly. So the first one about everyone can look after their mental well-being and find support in their communities. So in the strategy there's a few more details around this, but this is really about making sure people know what's available, how to access the support, and what's the most appropriate, including the VCSE. So one of the things that came across very strongly in the public survey was people's preferences to talk about problems with their mental health were family and friends, or professionals, particularly a GP or a social worker. But there's actually quite a lot of other options in Staffordshire for people, and it could mean people were waiting longer for support by waiting to get an appointment for something where there actually are quite good alternatives. So we want to make sure that becomes much easier for people to access. So then people have access to services when needed. This is acknowledging that actually at some points people do need more specialist support and services. So this outcome is around making sure people can access either through VCSE, the local authority, or the NHS when they do need it. 3, a timely response to crises. So this links into Chris's lead work around suicide prevention and unsafe social media use, and also acknowledging that people have escalating or very urgent mental health crises. And this links to some of the work in the NHS transformation around accessing crisis mental health supports through things like NHS 111, which is in their plan. The next one is equal access to support to improve mental wellbeing and services to manage mental health problems. And this is focusing again in an area that we had a lot of feedback around, which is where people that might have more problems accessing or are underrepresented. So the NHS colleagues have done a lot of work across the county about where certain groups of people appear as a smaller than you would expect group accessing services. And this might be people with disabilities or other protected characteristics. We've also included this young people who are care experienced. So there's a few groups of people which people identified as possibly being having more problem accessing the right support. The next one is people with severe mental health problems are supported to live in the community and have good integrated care. So this one then moves up into more about people who have got more long-term significant mental health problems, and this focuses around supporting more people to live in their own homes, so less 24/7 care in settings. This one is for both the NHS and social care. More people into employment, and there is already some good work. So there's an individual placement support that partners in the NHS have got already, very successful. So this is getting more people with long-term mental health conditions to gain and retain employment to allow them to live a more independent life. And then more joined up health and care system for people who might have complex needs and longer term support. And the NHS have got a number of transformation activities around better integration around primary and community care for people with long-term conditions. And then finally, this one focuses on more integrated good quality services for young people that focus on achieving independence to adulthood. So early identification of mental health problems for young people and more planned and better joined up transition into adulthood. So we work together across adults and children's. And so young people around there have more settled care arrangements. This is one we've talked to children's colleagues about, because actually if people move who've got quite complex needs, that's very disruptive to their education. And then for me, that makes getting into employment, into adulthood and living independently more of a challenge. So that's a flavour of those. And then on the next slides, we've given a few examples of work that's happening already. So some that children's have already got, or NHS or ourselves. So there's mental health leads in education network that's already happening in children's. There is the IAPT as part of the community mental health transformation, which is improving access to psychological therapies for people earlier on. On the public health side for Chris, strengthening mental health literacy and increasing resilience, and promotion of the 5 ways to wellbeing, which I would think is in the health and wellbeing strategy as well, Chris. So access to services when needed, improving access for children and young people to emotional health and wellbeing support. Mental health liaison services is part of the community mental health transformation. So this is where people go into general hospitals, but also have a mental health condition where they might need particular support for their mental health. And access for women and partners to specialist perinatal mental health services, and that is also part of the NHS transformation plan. So time response to crisis, so there is already a system-wide approach to reduce suicide and self-harm through the partnership plan, and we've included in the strategy the outcome to reduce suicides to below the national rate by 2025. And expanding, I've touched on already, so the NHS plan, they've got plans around widening NHS 111, so that includes people being able to get out of hours support 365 days a year. They can link into the local NHS trust, and also things like specialist ambulance provision for mental illness as well. So equal access to support. Again, I've mentioned children that are care experienced and people that may have other characteristics that make it more difficult to access mental health support. Severe mental health problems. So along with the other things we've talked about is in the strategy, there is from the health and wellbeing strategy a link into more of a focus on public sector organisations or anchor organisations to create employment training and volunteering opportunities. And I think in this as well, we're linking with colleagues in things like employment and skills in EI&S in the County Council. There is already work ongoing in the NHS around employment. And community, an increase in community support. So that we have more ability to offer supported living options for people rather than residential and nursing. And then the integrated good quality services for young people and transition. So there is work already ongoing around preparing for adulthood pathways, and for children's they've got a pilot of the Tell Me Wellbeing Peer Support app for young people that's already ongoing. The final slide, so underpinning how we're going to deliver on the outcomes is a range of approaches that we've identified. So underpinning this is helping people to help themselves. We've talked about, good information about how people can maintain their own well-being to prevent becoming a sort of a high level of a mental health problem. Build and use community capacity, so actually what came across for the engagement is people wanted actually to get support from their friends and family and their community, and there were loads of great examples where people felt their community had really supported them, so we want to build on that. So co-production runs through it. It's very much something we would do in social care, and also it's underpinning the NHS transformation. So for example, with this action plan, we would go back and co-produce with partners and people with lived experience and people working in those areas as to how we would deliver on it. Obviously, there's a theme about embracing technologies and what digital can offer. So again, we'd want to look at both technology-enabled alternatives, so online and apps, but also quite a lot of feedback around people having to tell their story multiple times, so better information sharing, so that people who are working with a range of people within the system, there is good information sharing across that. So minimise medicalisation, so strengthen people's personal resilience and also not just treating it as a condition, but actually looking at the wider determinants. So some of the things we've talked about, education, the importance of education, employment, community, those things that also can help people. Promote independence, so offer support to people's closest home and least restrictive options. So this is something where we don't over provide support, where people could actually or want to choose to live more independently, and offer support on that, you know, in line with what their strengths are rather than what we think we should provide them with. And also enable our workforce, so maintain their own well-being, but also to adopt the kind of the themes and the approaches within the strategy. That's an overview. So any questions from anybody?
That's what I was going to say. If happy to take questions, comments from anybody at all that wants to.
I think lots of really interesting things come out of your presentation, so thank you for that. One I was interested in is you talked about people's ability to look after their own mental health, and you also mentioned having resourcing to help young people in their mental health, and I just wondered at what point one begins to work with children to develop strategies to promote their own mental health, but also to look after each other in that respect, because I think there's a feeling that there are a lot more challenges for young people in terms of their mental health these days. I don't know how you quantify that, and I don't know how real that is, but it seems to me to be an area where, along with physical health, one would want, I think, to be giving people strategies and abilities to look after themselves as early as possible. I'd just be interested in your views on that. Thank you.
Speak for children's. Sorry. Wasn't it? Oh, it is now, sorry. So obviously Karen, our colleague from Children's, couldn't make it today's point, so I don't know whether Neelan wants me to. So I think there is quite a lot of activity already going on, and from the work we've done with Karen in schools, so I think some of that would lead to it. I don't know, Chris, because this is more well-being, whether you want to...
Well, again, it's something I think we need, that certainly from... Because I work in sort of adult public health, but I think we've certainly acknowledged it, certainly from the suicide prevention point of view, that it's an area that we probably need to work more closely on. There's a lot of work going on there, though. There's the now I've got to make sure I call it the right thing, but the Children's Integrated Board of Mental Health is quite advanced compared to the adult one, as far as I can see, and there's certainly is a much more effective partnership approach. And I know they've got a really good structure going, which, but Karen is the person that would really need to give you the answers to that.
So I think there's quite a lot already in the sort of Kind Minds programme with schools, and they've got some of the stuff Karen shared with us, promoted digital wellbeing. I think the thing for us with the adults as they move into is that making sure that, I suppose for me, from that preparing for adulthood, so it isn't, so I think some of the feedback we've had is that it can feel like a bit of a, I think some care are falling off a cliff, because I suppose when you're supporting a child, we do as a society support children more than we would an adult, and therefore in terms of how they maintain their well-being, that will change as they get older, and obviously they'll be more independent in their teens, and so they will have access to more other influences. So I think the transition element between adults and children's is kind of how, I suppose for me, how they maintain that well-being into adults. So once they leave a school environment, which possibly is more supported, parental, I mean, I've got 3 kids that are in their 20s, so obviously when they go to university and stuff, they're suddenly, so I suppose it's how we kind of more robustly prepare people as they kind of move into more independence. But Neelam, I don't want to put you in the spot whether you want to say any more on that.
So I'll just go in the order that people indicated, but I just will make a comment on the children's world before we do move on. I mean, there's a lot of work in schools with the Trailblazer programme, together with what was the CCGs in the past, and also the combined commissioning that we've got again around mental well-being in children's. Yeah, shame. Karen wasn't here because she'd have been able to answer those in a lot more detail because she's been living and breathing children's mental well-being. Gary?
Thank you, Chair. Really positive to see this, so thank you to yourselves and obviously everyone who's been involved in it. I know it's been quite a long time in the making as a strategy, and it's important, I think, to emphasise there's lots of really good stuff happening and that the strategy is sort of seeking to bring that together. It's not the starting point because there's lots of existing stuff happening, particularly under the community mental health transformation where there's some really, really good stuff happening, particularly around bringing together complex needs around drug and alcohol abuse and how that interacts with mental health. The partners or the partnerships that are perhaps you would expect to be there that are slightly less visible to me are around criminal justice and sort of probation, perhaps even sort of Staffordshire Commissioner's Office around domestic violence and the links between mental health and those partners. Can you give us some assurance that those partnerships are there, or is it covered somewhere else?
So yeah, so we did. So as in preparing it, we did look at the elements around the criminal justice system. So I suppose from other perspectives, so it came up in a number of areas. So we had focus groups with vulnerability hubs, which are where multi-agencies come together in the you'll be familiar with them. So I attended a couple of those and we met with those partners. So that is where, I mean, everybody knows those, but that's police, fire, social care, children's and adults, housing. So they very much are where. So I think when we go, so we did consult with them in it, and that did feed into that. Housing as well, they gave very good feedback around the sort of use of under the Mental Health Act. So there was a real linkage around there around obviously police respond quite a lot to incidents in the community where actually the person probably has a mental illness or a disability. So again, we consulted with the prison social work element where they are assessing people under the Care Act in prisons. Staffshire's got a lot of prisons. Again, you know, there's a high incidence of people with mental illness in prison, but also a learning disability or autism, and they're more likely to have co-occurring needs. We did meet with the League Commissioner for Drugs and Alcohol. So, as I said, there's quite a good link in with housing again, because again, of maintaining tenancies and problems with police and so they are there. I think it might not have, yeah, we perhaps haven't mentioned it, but yeah, it has definitely been part of it. Yeah, and that was part of the feedback.
Okay, Neelam and then Julia.
I was just going to come back on the point that Jan was making. I mean, generally, we find there are good systems in terms of mental health on the ground in the school settings, in our children care settings. I think our challenges are probably still to some extent with camp services and their timely availability, and particularly out of hours. And maybe there's a difference service provision in the north and the south of the county, and that's really what we are now working on and very much trying to find solutions to.
Thank you, Neelam. Julia?
Yes, thank you. I read an article last week about some pilots in schools down in Kent, I think, where they're looking to help school children almost self-administer CBT. And I think it's things like that. It's helping people to build up their own self-resilience. What always, in a way, horrifies me is when you see the statistics of the prevalence of mental health. That covers a huge range. And with the best will in the world, however much investment you get, that is a demand that cannot be met. So we have to look, as a county council we do with adult social care and a whole range of activities. That's why we work very closely with supporting communities, is actually helping our residents across the whole age group to become more resilient. We all know in life you have the ups and downs, and you know, we have to help people to know and have the confidence that they can actually deal with some of these. You then get people who obviously do need help, and we do need to ensure that they can get help in a timely way. Once they're back on their feet, that's fine, but often people then have a bit of a crisis. And what we were very keen on with any strategy, that people can dip in and out of the service and not have to go back to square one and then work your way through it, because of a timely intervention can prevent people from having a real crisis in mental health. I would like to thank Jan and her team. I should think Jan's got fed up of presenting various iterations of this strategy to me. She's grinning through gritted teeth. But I was very keen that we built on what was already in place and didn't duplicate, and that we had a document that spelt it out in plain language that we could all get to grips with and actually use a tool and a framework to make progress. And if we make progress on each of those 6 key themes, we will be doing what we all want to do, which is improve the population's mental health. So it is a much shorter document than perhaps traditionally, and it is such a broad subject. The danger is it becomes such a tome that nobody deals with it. But this actually, I think, gets down to some key issues that we can use this now as a framework with partners to make real progress. So I would like to thank Jan personally and her team and Richard. It's been a difficult journey, but I think what we're ending up with now is something that really adds value to what we're already doing, which is what I'm sure we all want. Thank you very much. Thank you, Chairman.
Okay, any other comments or questions? No? John, I take it, as I haven't got actual paper on this, it's just a presentation, there isn't any formal recommendation?
I think it's just a note for now, and we'll pick up mental health again next December anyway. So.
Okay, that's lovely. Thank you very much. So, Jan, thank you very much, Chris. Cheers. So, the next item on the agenda is Staffordshire Loneliness and Social Isolation Reduction Plan. Vicky, nice to see you again. You well? Good. Over to yourself then.
Thank you. I have shared a paper with the board, but the presentation I'm going to give is a summary of those details. Thanks, Chris. So I'm Vicky Rowley. I'm a commissioning manager in the Public Health and Prevention team here at Staffordshire County Council. Thank you. So, as I say, a paper has already been shared with the board. This presentation summarises the details within that paper, which asks members of the board to approve the development of a Staffordshire Loneliness and Social Isolation Reduction Plan, and asks that partners contribute towards that, and also asks for the board to receive future reports on progress of that plan in due course. Based on the research and work that's been done concerning the issue of loneliness and social isolation, a vision for Staffordshire and objectives have been developed that will guide us in the development of the reduction plan itself. The vision is to prevent people from feeling the impact of loneliness and make Staffordshire a place where people feel connected. The objectives are to develop a multi-sector reduction plan which encourages collaboration across individuals, teams and organisations across Staffordshire, to reduce levels of self-reported loneliness and social isolation by 25% for those in the highest risk groups, and to help at least 75% of those people understand how to stay connected. The definition of loneliness and social isolation can quite often get confused, which can quite often contribute towards the issue. Loneliness can be defined as a subjective, unwelcome feeling or lack of companionship And it happens when we have a mismatch between that quantity and quality of social connections of those that we want. Whereas social isolation is an objective state, whereby the number of contacts a person has can be counted. And the causes of loneliness are very individual, and they can vary based on our stages within life and the circumstances that we have, but quite often are linked to that person's sense of identity and their sense of belonging within their communities. I felt as though it was quite important to try and provide that distinction between social isolation and loneliness, but the relationship that they clearly do have with each other. It's quite well documented the impact that loneliness and social isolation can have on our health and well-being, and it's a significant public health priority. So the research suggests that loneliness and social isolation is linked to a number of poor health outcomes and ultimately early mortality, but those include higher rates of depression and cognitive decline. Individuals are also, that are socially isolated, are all more likely to access a variety of public sector organisations and services, but quite specifically, they're 3 times more likely to actually enter local authority-funded residential care, but also a variety of NHS services, including primary, acute and secondary care. Reducing loneliness and social isolation thereby improves quality of life for people and reduces the costs for us across the system. The research that we've carried out also looks into those that are most at risk of experiencing loneliness and social isolation across during their lifetimes. Older people, particularly widowed females living alone, young people, specifically students, and also people in rented accommodation, and those living with long-term health conditions. But there are also a variety of others that are vulnerable to the issues of loneliness and social isolation, including those with a learning disability, people with a mental health need, carers, and those that are bereaved. And there are also a number of circumstantial situations that can cause feelings of loneliness, such as moving to a new area, a new job, relationship breakdown, and so on. So there's a variety of protective and risk factors that need to be considered in terms of the development of the reduction plan itself. So the majority of the research that we've done has looked at the issue nationally, but we've also wanted to understand what it looks like for us in Staffordshire. So using the public health outcomes framework, the methods of collecting self-reported measures of loneliness and social isolation show that roughly over 20% of adults living in Staffordshire report feeling lonely often or some of the time, which is similar to the UK average. But specifically, the districts that have the highest reported prevalence of loneliness are East Staffordshire and Cannock Chase, and Lichfield has the lowest reported, self-reported levels of loneliness. It's also been really important for us to take into account the impact of the COVID-19 pandemic that it's had on people and their feelings of social isolation and loneliness, which in most cases has exacerbated the issue. And actually there are quite a number of people that are still feeling the long-term impacts of that we need to consider moving forward. So in terms of what we want to do, the evidence base suggests that there are 4 particular factors to consider in terms of developing a reduction plan. And our approach particularly would focus on the 5 ways to well-being, particularly the wanting to connect with people and help people to feel connected. But foundation services such as the NHS, social care and housing are opportunities to be able to reach out to people and upskill our workforces. Gateway services, which enable people to feel connected through things such as technology, planning approaches to our local environments and transport. Direct interventions, which help people to improve their opportunities for engagement through things such as befriending services and group activities. And structural enablers, which really create the conditions for being able to connect, taking an asset-based approach, and finding those opportunities to raise awareness, upskill our communities in terms of self-help, and create the right conditions to help people feel connected if they so wish. So the reduction plan itself will have a number of ambitions that sit within it, which will sit alongside the objectives to reduce the levels of self-reported loneliness and help people to understand how they can help themselves and feel connected. We'll use the research and evidence base available to us to inform what we do in Staffordshire, seek involvement from a range of individuals, teams and organisations, which we've started to do and will continue to do as the plan develops, and use the guiding principles that are suggested by national guidance, which are to collaborate across partners, take a whole system approach, and consider the issues of loneliness and social isolation across the life course. Which means in terms of the health and wellbeing strategy, this is relevant to each of the elements that sit within that, from starting well through to healthy ageing. So in terms of our next steps, we'll form a reduction plan with colleagues and partners that will be part of our approach to healthy age, to the health and wellbeing strategy. We will take our approach to a variety of other networks and partnerships to understand what's already existing in terms of opportunities for collaboration. We will use our Public Health and Prevention Supportive Communities programme to continue the work to help communities to feel connected and promote principles of independence and support people to feel supported by their families and communities. And we'll also share this work with the ICS Frailty Board, within which this will also sit to support their approach towards reducing impacts of frailty, as well as our mental health partners, considering the links with mental health and wellbeing. Thank you for listening. Any questions?
So Vicky, thank you very much for that. I'll use Chairman's prerogative and start by kind of get that frog out of my throat. And I'm going to be a little bit of a devil's advocate here, I think, is. And my question is why are we measuring reported levels of loneliness? Or why do we want to reduce reported levels of loneliness and not loneliness itself? Because if we just make it more difficult to report, we'll achieve that objective. Is that the right aim?
Yeah, that's a good question, thank you. Measuring loneliness is really challenging, and we've got very few mechanisms available to us to be able to do that. The Public Health Outcomes Framework provides that self-reported measure, which we are able to monitor. But I should have said there will be a variety of other ways in which we can do that, and identify those will be part of the reduction plan. One example, there's self-reported, but there's also the levels of risk as well. So based on a person's circumstances, a risk might be higher in certain communities than others. That information is available to us, but measures of loneliness also exist across our ICS economy in terms of the services that we provide and the engagement that we do with people. So we've chosen those because they're quite specific metrics that we are able to measure currently, but the aspiration is that we would be able to look at this holistically and understand a variety of different ways in which we can understand levels of loneliness rather than necessarily focusing on the Public Health Outcomes Framework.
Okay, thank you. Any other questions at all? Tim?
You identified East Staffordshire and Cannock as having higher reported levels of loneliness in comparison with Lichfield, and I wondered if you'd come to conclusions as to why that was. I can think of differences clearly between the profiles of the different districts and their relative wealth, for example, but not sure that they necessarily were clear determinants of that state, and just wondered what your view was.
Yeah, quite honestly, I don't feel in a position to be able to derive any substantive conclusions to that. Some of the research that I have done to look at their health profiles across a population shows some correlations with other factors that may have an influence, particularly linked with the work that colleagues are doing around mental health. The work that we're doing in supportive communities is suggesting that it could be a coincidence, but there's more that we need to look into to understand whether there is any sort of a causal effect happening for those particular areas that's down to economic or socio-economic factors that might have an influence. But I think this is what will drive the reduction plan, is to really try to understand that a bit better.
Thank you, Chair. If I may just briefly come back. I think part of what I'm interested in is I've spent a good chunk of my career working in inner city areas on major regeneration programmes, and I think there's often, it's easy to assume that in poorer areas you've got a reduction in the social infrastructure, but often I found that to be the opposite, that actually you've got greater connections within communities where people are facing economic adversity. And so I was just interested as to whether you'd been able to map any of those sort of issues relating to those districts, or whether it's too early in the work that you're undertaking?
Yeah, it does feel a little bit early. And I suppose a thing, again, I probably should have said is that I personally don't feel as though it makes sense to just rely on the data. I think it's part of the puzzle, really. So I think that taking that local place-based approach to really understand what's happening in those particular areas will help us to understand the public health outcomes framework kind of results and what they actually mean. So it's kind of taking it with a pinch of salt. It's useful to have it there, but there's probably more to it that we need to sort of discover.
Rita?
Thank you. It's not a question, it's sort of a comment and some information. Where I represent Purton, we recognise that there was a problem with social isolation. So myself and a fellow councillor in 2017, we set up the Purton Carpet Bowls Club with help from the National Lottery. And it's become one of the most successful clubs in South Staffordshire. We've got 50 plus members. We have social evenings, competitions, into other bowling clubs. And we thought that perhaps after the COVID pandemic, we would have difficulty with our members coming back. But literally, they were almost banging on the doors to come back. If people are lonely, they can just come in for a cup of tea and a slice of cake, which is what we have as the interval anyway. And it's just snowballed. So that's just an example of what one community can do. And, well, we started with 2 mats. We've now got 5. And we're having to think of whether we've got room for a 6th mat because we're so successful. But that's just one example of what communities can do. If you do a bit of research yourself and are willing to think of things that you could perhaps involve people with. And it's not just the social side. I mean, people are getting exercise as well. And they've actually built friendships, which they didn't have before. We have quite a few widowers who come, and they said if they didn't come to our club on a Tuesday and Friday, they'd just be sitting at home watching stupid daytime television. So from that point of view, it's a win-win situation, and it might be something that you could consider to promote to other communities. Say if you look within, you can perhaps find a niche that you could do something about.
Rita, I think that's an excellent example of how communities, working together can tackle this issue. Gary?
Thank you, Chair. It's really good to see this, all absolutely necessary and really welcomed. I'm mindful of the fact that this is an all-age problem, isn't it? And I'm just wondering, as we went through the presentation, whether there's an implicit assumption in here around the focus on the actions, that if you create the circumstances and the opportunities, people will naturally make social connections. And I'm not sure that's true for younger generations, and I'm particularly mindful of it in the context of the very big impact of social media. So if you take something like Facebook, that massively emphasises quantity of social connections over quality of social connections, I think we've got some quite strong factors that are pushing particularly younger generations into away from what we might think are natural ways of making social connections. So I almost think this in the planet, in addition to everything that's already in there, we almost need a kind of school or education of how to make good quality social connections, because I'm not sure everybody nowadays necessarily will do that naturally.
Yeah, I wondered it'd be interesting if on Facebook you had another section of real friends and not just the friends that you connect with. Did you want to come back on that at all, Vicky?
It was just to say that coincidentally myself and Julia had a really similar conversation when we were talking about this, and it was Julia's point that she raised to recognise the positive impacts that technology can have to solve some of this, but also the negative impacts amongst certain age groups. So it's certainly something that's on my radar as we move this forward. Thank you, Gary.
Jill?
It's just a comment, really. I'm just wondering, because the cost of fuel rising and the fact that councils and other organisations are going to be opening up warm zones, whether that might have an impact on this topic, because people will be congregating together and hopefully having some interaction.
absolutely. This is a real challenge, but I think for me it actually means it's universal, and there's lots of opportunities for people to actually achieve those connections. It's unfortunate that something like cost of living would actually do that, but it's taking the positive elements of that to try and understand what good we can do by connecting these different people and resources together within the community. So yes, I would agree with you.
And after Julia, does anyone else want to make a comment at all? Okay, in that case, I'll leave the final comment.
Yes, I think this is a good piece of work, and it does highlight how almost impossible it is to assess and measure your baseline, let alone your progress. And I understand the data that's available at the moment. I just wondered whether, or what would be the feasibility of perhaps people being asked to make themselves known if they feel lonely, and then using them almost like a reference group, that in 12 months' time you could ask them whether there'd been any improvement. You know, I'm using the example of when you have a knee replacement, you get contacted every 12 months to say, has it made a benefit of your life, etc., etc. But at least then you would have a fixed cohort of people, because otherwise it's such a movable feast. Who would have thought 2 years ago we'd have been hit by a pandemic that, you know, had such a major impact? Who else knows what's further down the line? You know, whether it's cost of living, there'll be something else that could actually impact on other people. So I'm just wondering whether that kind of more targeted approach to perhaps have a cohort of people who you could ask, you know, distributed throughout the county, but ask them after 12 months whether they'd noticed any difference, because otherwise it is an extremely difficult topic. But I do agree with Gary, and as you quite rightly say, we did have that conversation, because I think with a fair number of younger people, they can only communicate via this wondrous piece of kit and a screen, but actually are losing the ability to have that human-to-human interaction. And I think they're almost self-isolating in a way. How one overcomes it, I don't know, unless we start a trend of having an IT-less day. You know, it's not switch your email off, it's switch the whole thing off. You know, so that you can relearn, because we're human beings and we need that interhuman interaction. But I think it is a growing problem. And they all think they've got, you know, 3,000 friends. I often say to young people, if you've got that many close friends, you can phone up in the middle of the night for help. You're doing well. Thank you.
Paul?
Chair, I'm sorry, I know you said that was the last comment, but just if I could just build on that. I think there's also something about maybe looking at that preventative approach as well and building that in. You've got some very clear at-risk groups there. So, for instance, recently widowed older ladies, for instance, in there. Is there something that we could do about targeting those groups and picking them up right before they get lonely, and actually putting in place a plan as to how they avoid that? And maybe that could be something around looking at those reference groups. The only other question I was going to ask is in the structural interventions, I think you called it, the one thing that wasn't in there was family. And I just wonder whether there is something linking into, I know we do a lot in sort of adult social care and so on around strength-based approach, whether there is something around specifically talking around how we make sure family wrap around and use family to help us to build that. And it was just a thought that it wasn't actually specifically mentioned.
Thank you for that. It's quite specific within the work that we do in public health, particularly around our supportive communities programme, about how families and communities can support. So I will certainly make sure that that's reflected. Thank you.
No, okay, thank you for that. Okay, if there's no further comments or questions, and Vicky was good enough to read through the recommendations when she first started. So if we're So the first one is to approve the development of a loneliness and social isolation reduction plan, and that's that all partners contribute. And we've done the second one, and that's to receive the report. So is everybody happy with that? I'll take it that as a yes, because no one's indicating otherwise. Vicky, thank you very much for that. So the next item, item 5 on the agenda, is learning disability and autism. Is that your good self, is it? Because I know Karen Webb, that you are definitely not.
So Karen should appear on that screen very 1984 Big Brother style, I think, in a minute.
All the stuff that was going on behind.
Yes, and there she is. She's currently in a very cold Iceland, so she'll probably have better technology than we do. But thank you for the opportunity to present today. So along a similar vein as a bit in the presentation you just had for mental health, actually, we've done a piece of work around people with learning disability and autism and the challenges that face them. Some of the actually excellent things we've done as a system and where we move forward from here. And we just want to take the opportunity to bring it here today to update members. So I'll take the paper as read, but I'll pick up a few key points from it. So obviously, I think as everyone will know, people with learning disabilities have a range. You know, they could be very severe, they could be mild, but as a group they are disadvantaged by society. And there are a number of outcomes that we've looked at locally where you know, they have a poorer quality of life and a shorter life. And actually, we've done that as part of a Learning Disability and Autism Partnership, which was formed about 18 months ago. We've come together as a system involving statutory and third sector partners to look at how we can do this differently. And only last week, actually, NHS England commented on the fact that our partnership and our joint working is probably the most effective in the region in the way that we approach this. And we've seen some huge success stories around people who have been in long-term residential care for up to 40 years, who we've now actually managed to get over into a supported living setting local to their families and back in the local area. But there's still lots more to do. So we're focusing on 6 work streams, and just as high level, so they concentrate on actually identification and diagnostics. So the earlier we can diagnose this, but equally we don't want to overdiagnose, but the earlier we can assess that there is a need there, the sooner we can help and support. And all the literature says that the earlier you start, the better the outcome. A big section around community. So, you know, the title is This is Everyone's Business. Actually, a lot of people with a lower level learning disability don't need statutory services. The comment we get from particularly parents is, we don't want you, get out of the way. But if we need a bit of help, you need to help us get it. So there's a huge area on communities. NHS services in general, so they aren't always that accessible. We create services that are noisy. You know, if you've got a sensory sensitivity, that's not going to help. So there's something around specific NHS services. There's a work stream we're proposing around services for people with learning disabilities and autism and their needs, but equally not putting everyone through that. So there has been a tendency in the past of, you've got a learning disability, you're going into that service. Yeah, but I've got a broken arm, so you wouldn't send me that way. Slightly extreme example, but that is sort of what happens at times. And then also when we have those citizens who do have additional needs, whether that's provided through the local authority or through the NHS, how do we get that care and support right? So it provides the right levels of support, but it doesn't constrain their lives. And we've seen that, like I said, in the inpatient sector, we've seen huge numbers of people come out of those settings back into their locality, part of their community. But we've still got a way to go. And a lot of those particular individuals as well, because we don't have the provision locally, could be miles away. And we're not going to be able to create that capacity in the way that it exists at the moment in Staffordshire, nor do we want to. But actually, if we do things differently, we can get them back closer to their sense of identity. So those are the 6 work streams. What we are proposing jointly with the council and across the ICS now is to work up a sort of whole life disability and neurodiversity strategy. And one of my asks today is for you to endorse that approach and as consulting more widely. And then when we have pulled it together, that we come back and have a further discussion, and maybe not to upset John's neat plan of four work streams and 4 meetings, but actually we may want to consider how we build learning disability and autism into that in the future. And then I suppose my final ask is to all of you, both as people, but also in your role as counsellors, that you consider learning disability and autism in all your interactions every day, because it's only as a society which we shift to do that more and more that we actually will enable these individuals to have the most fulfilling lives that they can. So, thank you.
Thank you very much. Is Karen going to add anything to it?
I don't know if
Karen?
she's going to add anything, or she's just going to sit there quietly.
She's shaking her head, in which case we'll go to questions and comments. Tim?
I'm conscious I seem to be putting my hand up first. I'm happy to go after other people. One's a comment and one is kind of a plea. And I suppose the comment is just looking at the definitions within your report around learning disability and autism. It is, as you said, a very wide range of conditions, and it goes from people who may have, I forget what the phrase used, impaired intelligence within one, up to very high functioning people with autism. And so that's the observation. I suppose the plea is, I think we can, as employers, as well as people who provide services to the community, make a contribution here. And I think it would be really good to have some education, awareness raising and support for employers in terms of having a much more neurodiverse workforce. And I think there are, without wishing to be too stereotypical about it, there are a number of emerging areas of work, be that in IT and other things, which quite suit some of the personality traits or learning traits of some of the individuals that we're talking about, and whereas employers we could gain real benefit from that and provide a niche for people to come and work in conditions that are supportive and safe for them to do so. But to be able to do that, we need to have a greater understanding of employers, and our human resources departments need to understand, and we need to education and raise the awareness of colleagues to enable that to happen. And I think we'd be very willing partners as local authorities in that, and we have the links with the wider employers in our communities also to be advocates for that, if that is part of the programme that you're looking at. Thank you, Chair.
Do you want to come?
No, I suppose thank you, and I talked about that communities work stream, and that is one of the areas in which we are considering. And actually, when we look at the plan, some of it is very health and care focused, and we can get on and just get on with it, kind of thing. But with co-producing with the people involved, but some of it is much more that wider aspects, which is part of the reason for being at places like this and in other forums to pick up on those points where we can do more with this.
That's good, thank you. So, any other... Karen, did you want to...
Yes, sorry, it's just to add, Mark, that we are expecting to do a lot around employment. So we're quite poor as a system. We're not on our own in that. But actually, there are lots of people with a learning disability and autism that do want to get on and have an ordinary everyday life and do want a job. But actually trying to find those opportunities are really, really difficult. But what I would say is that we had an absolutely fabulous presentation from the police force, how they support their autistic officers. So there are lots and lots of people that are neurodiverse that have got everyday jobs, but the support that they require is slightly different. So lots of employers are starting to recognise it, but I agree we've got loads more to do. And the education part is something that we will concentrate in the work stream. Thank you, Chair.
Okay, thank you very much, Karen. So if there aren't any other points, the recommendations to the board is that we are asked to champion the cause of people with a learning disability and autism and encourage all organisations to make a contribution to improve their lives. B, to endorse the consultation to inform a Staffordshire joint whole life disability and neurodiversity strategy, and C, consider the Staffordshire joint whole life disability and neurodiversity strategy when it arrives. and I take it we're all happy with that, which looks like we are. So thank you very much, both. Oh,
Chair, I just wanted to put on record my personal thanks to Karen and Richard, actually, because this has been, there are no national definitions for how we count some of these things. This has been really difficult to get us to the place we've got to when we've got, and Karen in particular, but also Richard and his wife, we wouldn't have got here today and have a better understanding without their work. So it was just to put that on record. Thank you.
No, thank you very much, and it's good to see that items on the agenda today, you know, are talking about joint between the Health and Wellbeing Board and the ICB, and words to that effect, which is really, really positive. Move on then to the next item. So that is, the Staffordshire and Stoke-on-Trent Adult Safeguarding Partnership Board. Helen, do you want to come and sit up here? I think there's a couple of spots up here.
First of all, apologies from John Wood. John's really unwell, and you know how much he wanted to be here today, but unfortunately he couldn't be, so you've got myself and Ruth. Thank you. So the function of the Safeguarding Adult Board, Staffordshire and Stoke-on-Trent Adult Safeguarding Partnership Board, is to seek the assurance of effectiveness of multi-agency safeguarding arrangements in Stoke-on-Trent and Staffordshire. We're here today to ask you to acknowledge the Safeguarding Adult Board annual report for 21 to 22 in compliance with the Care Act 2014. As people have already mentioned, it's been a particularly difficult year with lots of competing demands, but we believe that the board has been well engaged with, and we've sought work streams and had engagement from people, some of which are sitting around here, both past and present board members. We're very pleased with the engagement and attendance that we've had at those boards and subgroups. Retrospectively, the annual report covers 21 to 22, but John would like me to point out that we have refreshed our strategic priorities and strategic plan this year, and have a new strategic priority of practical effectiveness, which includes 5 strands of work which we're hoping which have a very practical bias and will also address areas of risk with regards to effective practice. But we will report more on that in next year's annual report. And I invite you to receive the report and any questions or comments for myself and Ruth.
Well, that was very concise, Helen. So thank you very much. Thank you very much for that. Reports in front of you, and you heard what Helen's had to say. Do we have any questions or comments around the Adult Safeguarding Partnership, which, unlike many things that will come here, it's a joint one with Stoke, unlike the two children's boards, which are separate entities. No, that looks... Oh, Julia? Yeah, no, carry on.
Can I first of all say it's an incredibly detailed and very informative report, which I have read, and I'm quickly trying to find. There were 2 graphs, because there's the numbers of referrals that are made. There are relatively few formal investigations made. And there's quite a disparity in the proportion with Stoke-on-Trent and the proportion with Staffordshire, for which I got no idea what the explanation is, and I'm desperately trying to find the graph, but I think it's about 3/4 of the way through the report. And as I say, there's quite a disparity between the proportion that go through to formal investigation. They're much less as a proportion for Stoke-on-Trent than they are for Staffordshire. I wondered if you could throw any light on that.
Thank you very much. It's a question we get every year. And you won't be surprised to know we get exactly the same question when we go to Stoke-on-Trent as well. I will hand over to Ruth shortly, but basically, although we're a joint board, there is benefits in people retaining individualities, and Stoke have a very different approach to how they record their investigations. There has been work towards having a more aligned system, and at that point I'll hand you over to Ruth.
Thank you, Helen. Thank you, Julia. I think you're absolutely right to point it out, and I do come here every year to give the explanation as well. It is a question of at which point people choose to record a Section 42, what makes a Section 42. There's actually a 50-50 split across the country, so we're no different even within our local area. The fact that we have joint procedures actually doesn't denote or doesn't actually alter the way in which we almost record on our systems. I always say to people, just to give the assurance, that actually both local authorities respond in very much the same way to the concerns, do the same level of work into those concerns. And I've met on numerous occasions with our colleagues in Stoke-on-Trent, and we are meeting again in December. Well, it is December already, isn't it? It's the first today. So later on this month, where we're again going to be looking at actually our difference in recording. There will be some differences in this coming year from our changes in the way that we are recording more of our contacts and highlighting the amount. You might have seen this year that there has been a bit of an increase in the number of concerns comparatively to last year, but actually that's just our recognition of the amount that we have coming through. Those concerns don't always meet a requirement for a Section 42, but we are recording more of those. So it is just about us working out together as to where we sit. For me, the most important thing is knowing that the adults are getting the right response from both local authorities.
So this has given me a thought, because I was looking for the table or graph that Julie was talking about. And it's the one with the nice pretty pictures of the houses or the residential homes, etc. And it's got location of the abuse. And Staffordshire, 62% is from your own home, and 26% in Stoke-on-Trent. And then residential homes in Stoke-on-Trent are a lot higher than in Staffordshire. And a similar sort of question to Julia: is that a recording type of thing, or is there another explanation?
From the explorations that we've done, it does appear to be a matter of recording. It comes down to what people class as their own home. We've tried to be a little bit, we look at this from the person's perspective, and for some people, they see their residential or nursing home, or certainly for some people, supported living, as being their own home, which in that sense is quite a nice thing. However, it can sort of skew some of those figures, and again, when we look at it, there isn't that disparity, such a wide disparity. Although what I would say is that Staffordshire actually, just because of our population and our age, we have more people living within their own home as well, so that does make some difference.
No, thank you for that explanation. So do we have any other points or questions to raise? Richard?
Thanks, Chair. Not a point, but I just wondered whether we could put on record our thanks to John Wood for chairing the board this last year, and to Helen for coordinating the work.
Yeah, absolutely. I think I speak on behalf of everybody to say that and pass on our regards to John. So, Helen and Ruth, thank you very much for attending. Okay, so the next item on the agenda is item 7, which is delivering the Armed Forces Covenant in Staffordshire. Christian, do you want to come and find a seat somewhere? And over to yourself. Oh, sorry, Paul.
Chair, I'm very sorry. At the beginning, I should have declared an interest in this. I've recently been appointed as a trustee of the Royal British Legion Industries, which works with veterans around housing care and general support in the community. So I suppose technically it's an interest I should declare.
Okay, thank you very much for that.
Okay, thank you, Chair, and good afternoon, everybody. as it kind of says in the report, I'm the lead for the County Council on the Armed Forces Covenants. So just going to briefly today give you an update on the partnership work that's currently happening around the Covenant, about the partnership group, which we've resumed this year following the pandemic, to raise awareness of the action plan and some of the content of that we're delivering, and in particular to seek your support and endorsement for the health elements of that action plan, which we've pulled together with partners over recent months. So just as a very brief reminder, I'm sure most of you are very familiar with the Covenants. This is a promise to the armed forces, to their families and to veterans that they will be treated fairly. It's about recognising the unique role, circumstances and needs of this community and making sure they have a quality of access to services. In particular, it's about supporting the transition of service personnel when they are leaving the armed forces. And also, as I'll touch on shortly, a new act come into force just in recent days as well, which has some implications for all of us as public services too. So in Staffordshire, we've been at this for more than a decade now. We first signed the covenant, the County Council in particular first signed the covenant back in 2012. The armed forces are a big part of our community here. We've got a large presence at MOD Stafford, a large and growing presence at MOD Stafford, as well as the Defence Medical Service at Whittington, which is the home of the Surgeon General. We saw a large contingent of service personnel coming back from Germany a few years ago, and we have more of the Signals Regiment coming to Stafford in the coming years as well. So as I mentioned, we had a partnership group that's been working on the covenant for some time, which understandably went into a bit of abeyance during the pandemic. But I took on responsibility earlier this year. I was very keen that we brought that group back together. We recently had our second meeting this year, and have been putting together an action plan of kind of key priorities across local authorities, health, voluntary sector, and other organisations as well, working closely with MOD colleagues to make sure that we are delivering on our promise to the armed forces, families and veterans in Staffordshire. I mentioned the Armed Forces Act. This was passed last year and it has actually just come into force on the 22nd of November. This now enshrines the Armed Forces Covenant into law, and it means that all public bodies affected are legally obliged to have due regard to the principles of the Covenant when exercising specific functions, and that's especially in relation to healthcare, housing and education. For example, at the County Council, we're updating our community impact assessment that sits alongside all of our key decisions to make sure that there's specific reference in there to the armed forces and they are given due regard in all that decision making. So as mentioned, we've been putting together an action plan this year that builds on the great work that's been going on over the past decade. But it's important that partner organisations are able to see and understand the totality of the work that's going on in one place. The plan also gives us an ability to focus on the key issues that are affecting this part of our community and look for opportunities for closer collaboration where we can deliver kind of better impact. So the plan itself has kind of 4 key strands, which I'll run through a summary of shortly. The first of which is around data and IAG. From the recent census, we will have a much richer picture of the veteran community in particular in Staffordshire. We're already seeing some of that data coming through. The other elements of our action plan on this area are making sure, again, around that provision, that access, that equality of access to services, that we are providing the right information across all of the public sector to direct and signpost people to the support that's available in their communities. The part that's kind of most relevance to the board this afternoon is around provision of and access to health. So what we have been doing over the course of this year so far is linking in very much with our NHS colleagues to look at 4 things, one of which is increasing the number of veteran-friendly GP practices in Staffordshire, also veteran-aware hospitals, encouraging more veterans to register, identify themselves as such with their GPs, and exploring how we can further encourage GPs to use that veteran status read code. In terms of what that means in practice, so currently we've got 62 out of the 143 GP surgeries in Staffordshire and Stoke are veteran friendly, but the proportions vary quite significantly between the districts. So 80% of people in the Moorlands, for example, are registered with a veteran friendly GP practice, but that's just 15% in East Staffordshire. So a big focus for us over the coming months will be to promote the benefits of being a veteran-friendly practice to the GPs themselves, providing additional support and making it very clear that it's a simple process to be accredited by the Royal College of GPs and to promote the benefits of that. So we have a campaign that we are planning for the new year to step up that work. Also, as it says on the slide, it's about ensuring the community are considered through the JSNA, and ensuring that through our public health activity we pay particular focus to veterans as well as serving personnel and their families. I think I've touched on the legislation already. That's the kind of fourth strand of making sure that we are fulfilling our duty around that. And the final part of the duty on us and the action plan is around promoting the covenant, promoting things such as the funding streams that are available to projects in communities, and making sure that we as the County Council and our partners all times promote the role of the armed forces in Staffordshire. So my ask of the board this afternoon is just to note the progress that we've been making over the course of this year, having resumed the group, put together an action plan, and provided that focus around those kind of 4 priority areas, seeking your endorsement and support as we look to increase the number of veteran-friendly GP practices. We're setting ourselves a kind of target to try and have all practices signed up, potentially by Remembrance Day next year, to give us something to focus on. And also just to consider any other kind of priorities that you're aware of in your area that you may want to feed into the action plan. And I do have a more detailed version of that plan that I'm happy to share with the board as appropriate afterwards. Happy to take any questions, Chair.
Christian, thank you very much for that. We'll take questions or comments. Start with Jill.
Hi, I've got probably a good understanding of this. I'm an Army veteran myself, and retired Army welfare worker and retired Royal British Legion case officer for Staffordshire and North Shropshire, and I do welcome this. So I think it's been probably not a long time coming, but it's good that the act's been put in there and it's bringing everybody together. And my request is that we've got an officer at Newcastle that's recently in post as the Armed Forces lead, and if he could be invited to any meetings in the future, that would be ideal. His name's Dan Dickinson.
Yeah, and Dan's already been in touch with me, so he's on our invite list now for the partnership group. So yeah, that's already happening. Thank you.
Claire.
Thank you. Absolutely support all of this and happy to have some conversations outside of this meeting about how we can probably reflect some of those specific points within the action plan in the services we commission in public health, or the communication plan campaigns that we have, and all our wider kind of programmes. I'm thinking supportive communities in particular probably aligns with quite nicely. So yes, I'd like to see a copy of the plan, please, and happy to sort of try and see what else we can do.
Tim?
I imagine that all of the organisations represented here this afternoon have got Armed Forces champions, or most will. Christian, can you just confirm that you know, this paper, the contents of this, will be communicated to all of those, or are you looking to us to do that?
So the contents of the plan have already been communicated, in particular through the districts and boroughs will have representatives on the partnership group as well. So not necessarily looking for you to share the detail of this, but certainly to support and endorse in any conversations that are happening within your organisations. That would be really helpful. Thank you.
Paul?
And just to say, Christian, I mean, we've spoken before about some of this, but anything we can do to help in terms of GP practices. I mean, obviously, we commission and work with all the GP practices, so anything that we can do to help, and I'll chat to you outside on that and see what we can do to try and increase that number.
Yeah, and I was going to tap you up after the meeting around that particular campaign I mentioned, so thank you.
Julia?
I know this is particularly focused at public sector partners. But I think within Staffordshire, there are other partners who actually could play and may already play, I don't know, a very helpful role. We have in Staffordshire, and it's in my patch, is St George's Park, that have phenomenal facilities and activities for the whole range of professional sports people and local communities. And I just wonder whether a facility like that, with the status that they've got, being the heart of, dare I say, English football, whether actually they can be drawn in, because I think they could play a very useful role, particularly supporting veterans who, you know, a large part of their life is physical fitness. But I don't know, but I suspect they probably don't, in which case they need a nudge.
Sure, and that comes back to the kind of fourth element of the action plan around advocacy. And I haven't embellished on it too much today, but a big part of our plan, again, for, as we move into next year, is raising awareness, particularly amongst our business community and particularly amongst other organisations like St George's Park, to encourage even more to sign up to the Covenant. And we do have a number of the voluntary sector organisations on the partnership group as well. So encouraging more, as well as parish councils and the like, to come on board is a really important part of what we're looking to do over the next 12 months.
Gary?
Yeah, just building on that point really, I'm acutely aware that I'm a layperson with veterans in the room, but my observation would probably be that it feels like a bit of a tale of two halves really, in that once you've left the service and you're a veteran, it's an extensive, active, thriving, I would almost say, community voluntary sector. There's significant amounts of provision, there's significant amounts of need, but there's significant amount of provision. There are projects under the mental health work that we talked about earlier in the meeting that's focused on veterans and partnerships. There's stuff around some of the loneliness stuff that Vicky presented earlier, which is similarly focused. But that's once you're a veteran. The flip side for me is whilst you're still in the service, and I think this is understandable, and as I say, I'm a little nervous saying this as a layperson, but my observation of being involved in the Covenant is that whilst you're serving, there's very much a culture of we look after our own, we're responsible for our own, and we look after our own. So in terms of community involvement, it feels quite an abrupt transition. Almost from we don't need to rely upon the community. If we're seen to be relying on the community, we're somehow not looking after our own, we're not fully being responsible in the way that we should be, so we don't need the community. And then you're a veteran and we need the community, so it's quite abrupt. So I would say we've got loads of voluntary organisations that are involved with veterans, very few involved with serving personnel because they tend to look after their own.
That's a interesting comment. It makes you think. I don't know, Christian, whether you want to make any sort of comment on that at all. I'm not.
I think it's a fair observation, and I think there's work to be done. I recently went and met with the Lieutenant Colonel who oversees the base at MOD Stafford, just to see if we can build closer links there, and he has now joined the partnership group. So I think small steps like that hopefully will hopefully break down some of those barriers. And I think there's a lot of work that's done, in particular through things like the cadets, kind of prior to potentially people going into the armed forces as well. But I think it's a fair challenge and something we need to think about moving forward.
Okay. It doesn't look like there are any other questions or points. So, Christian, thank you very much for that. The recommendations I won't go through again. Christian's already read them out when he started his presentation. So it's just the ask whether we are happy with the ask of us, and without any note to the contrary, I'll take that. Yeah. So thank you all very much for that. And again, thank you, Christian. So we move on now to items 8 and 9, which are in your pack, which there's no presentation. They're just for your information and to be able to read at leisure. That's the fireside study update and the JSNA update on the census. And then that will take us through to the final item, which is item 10, which is the forward plan. And dealing with the next meeting, which is according to this, is the third of, that was the first one of the last year. So let me go to the end. Yes, the 2nd of March of next year, which on the agenda so far we have the strategic metrics baseline, healthy ageing priorities progress update, the ICS and commission intentions of the ICP strategy, the Better Care Fund, and whole life disability and neurodiversity strategy. Is that about it, John? Okay, thank you very much. So unless anyone has any last minute comments at all, thank you all very much for your attendance today. And it'll be the new year when we meet again. So have a very enjoyable Christmas and New Year period.